to have the opportunity to present a historical review on nuclear oncology in Japan with emphasis on dosimetry of internal exposures. I wish I could be in Baltimore, where I lived once upon a time as a research fellow of nuclear medicine at Johns Hopkins Medical Institutions. I have lots of good memories of Baltimore and vicinities more than 50 years ago. I have no COI to declare in regard to this presentation. For the next 30 minutes or so, I will talk about nuclear oncology in Japan, a historical review, diagnostics in nuclear medicine, current interest, and a dosimetry for internal exposures. In the annual scientific meeting of the Japanese Society of Nuclear Medicine to be held November 7 to 9 in Yokohama this year, 3,500 of members of Japanese Society of Nuclear Medicine will celebrate 60th anniversary of foundation of the Japanese Society of Nuclear Medicine. An epoch-making event in the history of Japanese nuclear medicine and world nuclear medicine as well was the holding of the first World Congress of Nuclear Medicine and Biology, September 30 to October 5, 1974, just 50 years ago in Tokyo and Kyoto. We had the honor of attendance of the Crown Prince Akihito and Crown Princess Michiko at that time, His Majesty the Emperor Emeritus, and Her Majesty the Empress Emeritus at present. The Peace Bell, a precise replica of the Peace Bell presented by Japan to the United Nations, was sounded once by the Secretary General, the late Dr. Masahiro Iyo. Striking the bell at the opening and closing ceremony has become the convention. Dr. Henry Wagner Jr., professor of nuclear medicine at Johns Hopkins Hospital at that time, wrote in his book entitled Personal History of Nuclear Medicine that the Japanese had taken a great risk financially in holding the first Congress. Fortunately, the meeting was a great success. The World Congress has been held every 4 years in a different country, in a different continent. In September 2022, the 13th Congress was held in Kyoto for the second time in Japan, with Professor Kinuya as president, who struck the peace bell 13 times. In the 1960s, scintillation scanners and iodine-131 level radiopharmaceuticals were used for nuclear medicine imaging. Thyroid scintigraphies were taken 24 hours after oral administration of sodium iodine-131 iodide for detecting cancer as a cold nodule and functioning adenoma as hot nodule with increased radioactivity and suppression of the normal thyroid tissue. Iodine-131 aldosterol, an analog of cholesterol, was used to detect functioning adenomas in Cushing syndrome and Cone syndrome, with suppression of the contralateral normal adrenal gland. It was fortunate that ANGA-type gamma camera with a large field of view and thin crystal detector and technetium-99M with low energy of 140 kiloelectron volt of gamma ray and a short half-life of 6 hours became available at the same time in the 1960s. This so-called happy wedding revolutionized nuclear medicine practices. The most frequently performed nuclear medicine practice have been bone scintigraphy for detection of bone metastasis. This slide shows the state of in vivo nuclear medicine imaging based on the 7th nationwide survey of nuclear medicine practices in Japan, performed in 2012. The survey was performed every 5 years since 1982 by Japan Radioisotope Association, or JURIA. Tumor imaging in 1992 was ranked in the third, following bone and heart imaging. Radiopharmaceutical used was gallium-67 citrate. Thorium-201 chloride was also used for tumor imaging. The use of gallium citrate rapidly declined after 2006, having been replaced by FDG PET, positron emission tomography. We applied solid-state beta detectors for oncology as well as cardiology. A small silicon PN junction diode was put into the catheter tip. The device was named Catheter Type Semiconductor Radiation Detector, or CASRAD. It was inserted in endoscopic device in place of biopsy needle. The accumulation of phosphorus 32 injected 24 hours earlier was detected using this beta detector in the upper GI tract. The areas of infiltration of gastric and esophageal cancers were demonstrated as increased count rates as compared with normal tissue. The detection helps to identify cancer tissues to be appropriately biopsied. Radioimmunoassay, or RIA, was invented in 1957 by Burson and Yalow, who received Nobel Prize in 2004. RIA and other in vitro radioassays shown in green, which uses iodine-125 as labeling and well-type situation counter for counting radioactivity, had been increasingly used in 1970s as routine clinical tests. In vitro radioassays boomed in 1980s, reaching a peak in 1987, since when radioassays were rapidly declining, having been replaced by non-isotopic methods. Various tumor markers measured by RIA have been used to follow cancer patients. Those slides show a clinical application of carcinoembryonic antigen, or CEA, in cancer patients. The left-hand side panel showed a rapid decline of serum CEA after resection of colon cancer, which indicates success of the operation and good prognosis. In the other case of colon cancer, declined serum CEA after operation continuously increased, again indicating recurrence of the cancer and bad prognosis. Labeled antibodies against the tumor antigens were used to visualize cancer sites, as the antibodies bind the tumor antigens which were expressed on the surface of cancer cells. This new technology was called radio immunodetection, or RID, and attracted great interest in the 1980s. At this point, we are aiming at radioimmunotherapy, or RIT, although it took another decade to be routinely performed in nuclear medicine practice. We conducted a clinical trial of IMASIS-1, which contains fragments of monoclonal antibodies against CEA and CA19-9, labeled with iodine-131 and mixed as cocktail. Lesions are clearly visualized 96 hours after intravenous injection of IMASIS-1. In other cases, with gastric cancer shows increased accumulation of IMASIS-1 in the posterior view of the abdomen. In middle of 1980s, we started to use a single photon emission computed tomography, or SPECT, with thallium-201 chloride, mainly for myocardial perfusion imaging. Our group in Gunma University started to use thallium-201 SPECT for the detection of tumor and malignant glioma of the brain. The thallium SPECT of a patient with malignant glioma shows similar appearance of as FDG, positron emission tomography, and the images are different from technetium DTPA image, which demonstrate the blood-brain barrier disruption, and also different from iodine-123 IMP image, which reflects brain perfusion. In Japan, first PET, positron emission tomography center, was established in 1979 at National Institute of Radiological Sciences, or NIRS, in Chiba. The first domestic positron emission tomography was named Positologica 1 and was used to take brain PETs. When a clinical PET center was started in 1984 in Gunma University Hospital, a PET and CT machine were installed side by side, as shown in the slide. A patient bed was moved electronically so that PET and CT images were taken exactly in the same position. PET images of brain was superimposed on the same slice level of CT. An example of a combined image, which is now called a fusion image, demonstrates a tumor accumulating carbon-11 methionine located in the sphenoidal ring. This parallel type PET-CT was a prototype PET-CT, which was later commercialized in 2000 as a system with PET and CT combined in tandem. A great invention of Townsend and Bayer in Pittsburgh, United States of America, became standard imaging instrument used in nuclear medicine practice today. This slide shows the present state of in vivo nuclear medicine imaging based on the 9th nationwide survey of nuclear medicine practices in Japan. The survey was performed, as I mentioned earlier, every 5 years since 1982 by Japan Radioisotope Association, or JURIA. The 9th survey was conducted in June 2022. The statistical analysis revealed about 1 million single photon studies were estimated to have been performed more than 900 hospital facilities in the year 2022, 68% of which was SPECT. About 700,000 of positron emission tomography or PET were estimated to have been taken in more than 300 facilities in the year. National Health Insurance Coverage FDG PET was approved in 2002. Commercial delivery of FDG was started in 2005. These two epoch-making events accelerated the rapid increase of PET facilities in Japan, and PET studies have been increased, partially replacing SPECT imaging. Number of PET and PET-CT examinations reached 710,000 in a year by 2017. Single photon imaging has been gradually decreased, although the total number of in vivo examinations remains about 1.8 million per year in Japan. FDG are used with purpose other than routine medical examinations under National Health Insurance System. A unique application of FDG PET in Japan is its application for health checkup for healthy subjects. Nearly 15% of FDG PET in oncology is performed as health checkup as free practice. Use of PET for health checkup of non-symptomatic subjects is a controversial issue. I believe it is useful for a limited group of people with higher risk of cancer, which include older people over 60 years old. As I have experienced such cases as shown in this slide, a 60-year-old male received PET health checkup, which pointed out a nodule in the lung with FDG accumulation. The lesion was diagnosed as lung cancer and resected without recurrence. The patient remained healthy thereafter. Dr. Wagner stated in his book entitled A Personal History of Nuclear Medicine that, quote, in the 1940s, the first report of the use of radioactive iodine and to treat diseases of the thyroid and radioactive phosphorus to treat leukemia were greeted with great enthusiasm by medical professionals and public. These classic findings were immediately recognized as forerunners of a whole series of similar radioactive magic bullets to seek out and destroy diseased tissues within the human body. Therefore, radionuclide therapy is an old story started in 1940s. This slide shows recent trends of radiopharmaceutical therapy in Japan. The numbers of radiopharmaceutical therapy have been rapidly increasing in recent years in Japan. The most frequently used radionuclide for therapy has been iodine-131 for the treatment of hyperthyroidism and thyroid cancers. Use of strontium-89 chloride for bone pain palliation had increased rapidly since 2007, reaching the peak in 2013. Unfortunately, its supply was stopped recently. In 2017, radium-223 dichloride was approved for use under National Health Insurance System and was used for about 4,000 patients with castration-resistant prostate cancer with bone metastasis. Lutetium-177 dotatate was approved for clinical use in November 2021, with which somatostatin receptor positive neuroendocrine tumors are started to be treated. This slide was provided several years ago by Dr. Shoko Takano of Yokohama City University, who eagerly promoted theranostics in Japan. Peptide receptor imaging using Injum 111 dotatok together with abdominal CT revealed multiple metastases in the liver with somatostatin receptor expression in a 60-year-old female patient with neuroendocrine tumor of pancreas origin. The patient received peptide receptor radionuclide therapy using yttrium-90 dotatok 3 times with remarkable effects as shown in this CT image. The patient had to travel to Basel University in Switzerland as the radiopharmaceutical had not been licensed for clinical use in Japan at that time. Theranostics is a coined word binding therapy and diagnosis together. The same radiopharmaceuticals can be used for diagnosis labeled with gamma-emitting radionuclides and also for therapy labeled with beta and alpha-emitting radionuclides. Radiopharmaceutical labeled with iodine-131 has been used both for diagnosis and therapy, as iodine-131 emits both gamma and beta rays. Yttrium-90 and lutetium-177 have been used for therapy as beta emitters. Alpha therapy, like actinium-225 PSMA, showed better treatment effects than beta therapy with lutetium PSMA. In the castration-resistant metastatic prostate cancer, as shown in a well-known case demonstrated with gallium-68 PSMA PET images. Alpha emitters such as astatine, radium-223, and actinium-225 have been attracting great interest recently to be used in theranostics. International Commission on Radiological Protection, or ICRP, has published coefficients of radiopharmaceuticals such as fluorine-18 FDG in terms of absorbed dose per unit activity administered, or milligray per megabecquerel of administered dose. Using these values, medical internal exposure of patients caused by nuclear medicine imaging procedures can be estimated by knowing administered quantity of radiopharmaceutical to a patient. For an example, 200 megabecquerel of FDG intravenously injected costs 1.2 milligray to the heart, and the effective dose of 3.8 millisievert. In nuclear medicine practice, given dose can be precisely known, which is good news. However, organ doses are estimated in reference healthy person of different ages. In a patient with certain diseased conditions, distribution of a radiopharmaceutical may be different from healthy condition. The difference can be significant, which is bad news. Radioisotope internal use therapy, as originally called RIT, PRRT, or in other names as called today, is the same technology, and the technology requires treatment planning for individual patient, patient-specific dosimetry for assessment of absorbed dose to normal organs and tumor tissues. The amount of activity administered should be sufficient to treat the neoplasm effectively, while minimizing any detrimental dose to normal tissues. In other words, maximizing the radiation delivered to cancer without exceeding normal tissue tolerance value, with particular attention given to critical organs such as the kidney and the bone marrow. In order to achieve the requirements, time and the amount of radioactivity administered, amount present in organs and tissues, as well as time-dependent retention and clearance from the organs and tissues, must be measured using images taken by gamma counting. For those purposes, quantitatively accurate imaging is required using appropriate equipment, software, and by skilled personnel. Repetitive imaging is necessary, though the burden to patients has to be minimized in practice. Therefore, absorbed dose calculation in individual patients is a challenging issue at present. I have experienced the progress of nuclear medicine in Japan from its dawn to present. The road of nuclear medicine has not been a smooth one. The coordinated developments of instruments and radiopharmaceuticals promoted nuclear medicine like the two wheels of a vehicle. Similarly, nuclear medicine has been successfully operated by the tremendous cooperative efforts of physicians, technologists, and other specialists in related fields, like all four-wheel drive of a vehicle. Likewise, multi- and transdisciplinary cooperation should strengthen the future development of nuclear medicine. Thank you for your attention.